Okay, welcome back from lunch for those who are at IARC. And I also welcome the participants who are joining online because this is a public event. And this is essentially focusing on implementing cancer screening programs. As we know, cancer screening programs are one of the most challenging public health initiatives. And we really need to make sure that we plan well and we execute the plan appropriately. So to discuss about this, we have two wonderful speakers. So I have my colleague, Dr. Andre Carvalho, who is also with me at the Cancer Early Detection, Prevention and Infections branch at IARC. So what Andre will be talking first about implementation research, which is a new buzzword, a very important area in public health, implementation research, and how we can utilize the concept and framework of implementation research in measuring or evaluating the pilot cancer screening programs. Over to you, Andre. So if you would like to come here and talk, that will be better.
Thank you, Partha, for the introduction. So we're going to start by talking a little bit how implementation research can help to better evaluate a pilot project. With that, we need to discuss a little bit, that the implementation research principles play an important role in designing and scaling up cancer prevention interventions and programs. It's how you can plug in implementation research when you are trying to pilot and thinking about scaling up an intervention. And that these principles provide a systematic and evidence-based approach to understand how interventions can effectively be implemented and, most important, be sustainable, right, in real-world settings. What we need to understand is that what we're trying to do is bridge the research and practice gap. What we know is that it takes around 17 years for 14% of the published papers to become something in real life. How can we do it better? How can we do it in a short period of time? Right? How can we increase the adoption, reach, and impact of evidence cancer prevention and care in real settings? So we as scientists do the science push, right? We create evidence and we try to make it come to the real setting. The market is going to do the pull as the demand. Usually those evidence base is necessary, but we need to understand the delivery capacity. We need to understand if the health system is ready to incorporate what we're talking. And the best way to try to see that is to pilot an intervention, but also to measure enough performance indicators that you can understand what you need to scale up. That's where implementation research has its role when we talk about trying to implement new interventions, trying to scaling up new technologies, trying to implement a new cancer site screening, and so on. So we want to increase the number of services being provided, the number of practitioner providing. So capacity building is also important. We need to understand if you have that capacity, and if not, how we're going to train and how long we're going to take to train, right? Partha said, okay, if I buy you today 100 mammograms, where are your technicians? Where are radiologists? How long are you going to take for you to educate people on that level so you can put that machine to work? So all of this needs to come in practice, as in the end of the day, we want more individuals receiving that evidence cancer as we can improve population health and patient well-being. It's also important for us to comment that implementation research come in different colors, shapes, and flavors, right? We also need to understand what we're trying to measure. There's implementation outcomes that we can measure, like acceptability, adoption, cost, feasibility, fidelity, and so on. There are also the systems outcome, where we want to see the efficiency of the system, the safety, the effectiveness, the equity, more and more. We want that to be delivered for everybody in the society, not for the ones that has easy access to. How can we do that without leaving anybody behind, right? Is this patient-centeredness, is the timeless. But also in the end, we want to measure patient outcomes regarding morbidity, mortality, as we want to change incidence and mortality for cancer. And we need to incorporate monitoring and evaluation, understand operation research, and see how to measure this impact. When we talk also about implementation research, we need to understand that there is a time when we do research that implementation research fits. When they're still trying to prove of concept, if it's safe and if does it work, this is not the place for implementation research. When we're moving for the proof of implementation, how does it work in real world setting is when we can begin to think about, but the first ones that prove that it works might not come as a full implementation research. Once we see that the evidence works, is that we want to scale up, that we want to really put at test in real settings, that's when implementation research is most likely helping us. Let's see what are the principles of this research that we need to keep in mind when we plan. This needs to be contextual adaptation, right? This is tailored for the local context. This is the main problem, that what is evidence-based in an academic institution, in a small place that we do in a country, does not work in a different country, does not work nationwide, because they're not considered the local context. So this is very important. That's where we see if this is acceptable, if this is feasible in your local setting. This should the evidence-based decision make, right? Whatever we do this, the implementation research integrates the scientific evidence with practical knowledge gained from the real world settings. We need to do this link, right? That whatever is evidence-based might work or not. So we need to know, refine this intervention, need to know if the intervention is effective, efficient, and yield the desirable outcomes. We also need to think about how we do evaluation and continuous improvement. So it's a cycle, right? We measure, we take decisions on what we change, we put it in action, we measure again, and we go. That's how we always have this model moving forward and also move upwards in terms of improving quality and improving coverage of the services. So this systematically monitoring of evaluation also that identifies gaps, bottlenecks, and areas for improvement that we can use for this continuous improvement. We want to have stakeholders engagement and collaboration. We cannot scaling up without having everybody. We can do a pilot eventually, but it will not be a good pilot. But definitely we cannot scaling up without engaging the stakeholders. And we have been discussed a little bit about stakeholder mapping, stakeholder engagement, and this is quite important. So we can bring together, the multiple stakeholders, that the ownership is there, that everybody express concerns, restrictions they have for the intervention to be implemented. And then we can move forward together and try to overcome any obstacles, any barrier that's put in there, but also understand the facilitators. The main point here is ownership, sustainability, and a better alignment with the local health system. We cannot just import something that doesn't work in your health system. And it will only work in your health system if everybody's on board. Sustainability and scalability, right? Another, big issue. How can we make it that sustainable and scalable at the same time? And we're gonna see some presentation from Cheryl showing a little bit how that works in her country. is this how you can identify strategy for the long-term sustainability. This should be something when you're doing a pilot is different when the academics are doing a demonstration or a non-government organization is doing a demonstration. A pilot should be something that we're thinking about scaling up, we're thinking about bringing up to everybody in the country. And then we need to understand who's gonna pay for that, how we're gonna make that sustainable in the long run. And finally, right, about the dissemination and knowledge transfer, or someone will also understand as exit strategy. A lot of times we do the pilot together with researchers that were involved in the evidence base, or academics, or someone that's external help with the implementation. But this cannot, or sometimes a non-government organization comes with this idea of a pilot. But the problem is that when they leave the project and the pilot is gone, who's gonna take care of it, right? When they leave with the funding, who's gonna sustain it? So every time we're thinking about a pilot and scale up, we need to talk about how we're gonna transfer, disseminate the knowledge, and do an exit strategy. That there is a time that, you know, those leading the pilot, if they're external stakeholders, they transfer everything and they move away, and all the ownership stays with the local. And finally, you know, we need to talk about the implementation research frameworks. As I start saying, you know, implementation research, it has multiple uses. When we talk about tobacco control, we talk about policy to avoid, you know, tobacco to get to the public. But once you have some smokers, we begin to talk about smoke cessation, and this is behavior science. Right? And if you talk about implementation research on smoke cessation, this is going to have a lot of behavior science behind. So there are frameworks that should be used for that. When you're talking about implementing a new technology in your cancer screening program, like moving from cytology to HPV, this is way more related to your practice, to your health system, to the costs of it. And this is a different framework. You're going to have different outcomes than when you're studying something that's related to behavior of the population. So the use of frameworks provide this structure and systematic approach to studying complex process for implementing interventions in the real world, and offers a set of guiding principles, right, that allows you to easily measure your outcomes, other than just trying to figure out by yourself. I'm going to cite a few of them that's mostly used, but there are way many others. So usually one thing also for you to do is that whatever you select an intervention, try to look in the literature, what framework they use when they decide to do implementation research, when they decide to take enough information to move forward. Right? So this is a few examples for you to get a little bit of taste that what we're talking about measuring and doing as a framework in implementation research. So one of the most common is the REAIM-1, AIM, right? That stands for reach, effectiveness, adoption, implementation, and maintenance. We're talking about how do I reach the target population? If this is an issue for your intervention, right, then this might be one framework. Also, how do I know my intervention is effective? Is this the framework? How do I develop the institutional support to deliver my intervention? How do I ensure interventions deliver properly? How do I incorporate the intervention so it's delivered over long term? So if those are kind of the questions you want to answer, this might be your framework. But if you want to make it a little bit more complex, right, and not only put the REAIM, you have the PRISM, that's from the same group, that incorporates way more layers of complexity. The AIM is just in the three green oval spots there. All the rest is part of the Prisma. So the Prisma incorporates the re-aim, but talks about a practical, robust implementation and sustainability model. That's where you begin to talk about who are the recipients and what are the interventions in terms that what is your organizational perspectives in terms of the leaders, the managers, and the staff regarding the intervention and who is receiving. Same thing from the patient perspective, how they accept this intervention, how they're going to receive it. But also we're going to begin to talk more and more about what are the external environment you have to consider. That goes a lot of the local context, but also the implementation sustainability structure for scaling up. So this is kind of a plug in the re-aim for you to scale up. The other very well-known and used is the consolidate framework for implementation research. That makes you, understand a lot of the inner setting, when we talk about structural characteristics, the culture, the transition for training, right? The compatibility, but also the outer setting, right? That measures about, the critical indicators, the values and beliefs, the systemic condition. We're plugging how my innovation comes here in terms of the source, the evidence base. So it's way more complex about, telling you to think of all that's involved when you're trying to implement. So it's all depends, what is the size? Are you trying to do a small change, or you're trying to restore your health system so you can incorporate way more things in your new intervention? Another framework that goes way more for the behavior science is the theoretical domains of framework. Right? When we begin to measure, more than 15 domains regarding to social influences, to environment, context, and resources, social role and identity, beliefs about capabilities, optimism, intentions, goals, beliefs about consequences. So it's way more related to behavior. So if your intervention is about changing behavior of the population, even in screening, if your problem of bringing someone for screening is the behavior of the population, you might want to get your implementation research trying to change that part. And then some frameworks is better designed to cover that. And finally, just as citing here, right, the explanation, preparation, implementation, sustainability, the EPS one that put together the outer context, the inner context, the innovation factors, the bridging factors, but thinking about how you do the preparation, how you do the implementation, how you do the exploration, and the sustainability. Okay. And the other one is the implementation science framework, again, that thinks about funding, climate, existing research and theory, and micro policies, moving way more also how you can change policies in terms of implementing prevention, supporting the work, and distilling the information. It's a lot of information to bring, right? So I would like to bring this website that talk about, dissemination and intervention models, Web 2. This is not about, a checklist that you put what you are doing and they give you the best framework, but it goes stepwise. What you need to think when you are implementing, planning your implementation, selecting what you're going to implement, combine or consider what you're doing, how you're going to adapt, how you're going to use, how you're going to assess. For each of these, there are instructions and questions of what you should think about. And in the end, it helps you to create your framework, to create the whole process, right? And this is something important for you to get more, for those interested to get more, in contact with what are the questions that need to be answered to think. There is one big issue that needs to be fixed together, right? Because we're talking about implementation research, we're talking about collecting a lot of data so we can make better judgment and better decisions that is based on data, is that data and information system are quite challenging in low and middle income countries, right? And this has been the norm. We have been working a lot on trying to get information on cancer prevention and cancer screening, and you here, went back to try to see what data was there for your country, so you know the gap on data. You need to improve that. You cannot create something that only works when you're doing the pilot, right? How you create a system that whatever data you're collecting for the pilot is in an information system that can be there afterwards, right? So we need to capture for sure and monitor for the pilot. We need to ensure data privacy and security while facilitating data sharing for research and evaluation. But we need to implement sustainable solutions. And we saw over and over again that the pilot is based in a fancy, expensive software that the country has no money to incorporate that in their health system afterwards. So this is something to put into consideration when designing a pilot. You can work with an Excel spreadsheet for a pilot, right? Would that work in real world afterwards when we scale it? It might, but we went to visit countries that many of the health facilities don't have a single computer. So how are you going to deal with that? You can buy 10 computers for the 10 sites that you're going to include the first time. How are you going to buy 2,000 computers afterwards? So all of these, how you continue to get data so you can continue to evaluate, you need to put that into perspective as well. So in summary, implementation research principles are of great value in designing and scaling up primary and secondary preventions for cancer control programs. By incorporating these principles into program planning, stakeholders can develop evidence-based interventions that are tailored for the local context. You better engage the stakeholders, and it's better for evaluate the program performance and ensure sustainability. Key word here, sustainability. That's the only way for scaling up and take this in the long run. Using frameworks in implementation research provide a structure and systematic approach to study implementation process, and that's what we're trying to advocate here. Incorporate the concept and the methodology of implementation research when you're doing your pilot. And finally, we believe that this approach enhances the effectiveness and the impact of cancer control strategies. Thank you so much.
Thank you so much, Andre, for very nicely presenting how the concepts and the frameworks of implementation research can be applied when we are running a pilot, evaluating a pilot, and even maybe scaling up a program. It's now my pleasure to, just before that, maybe let me tell you, I will take the questions at the end of both the lectures, right? So it's my privilege to invite my good friend Sharon. Sharon is the public health expert at the sorry, maybe we need her slide here. Yeah, okay. So Sharon is the public health expert in the Afro region of WHO, and she has great experience in running, implementing, and supporting cancer screening programs. Over to you, Sharon, please.
A very good day to you all. So it's good morning to some who are watching, good afternoon here, and probably good evening. And today I was listening to the great presentation that Andre was just doing, and mine is really to bring the practical experience aspect, what you saw and how it will actually look on the ground, or how it comes out and what happens after that. So slightly taking off my WHO hat to really look at the journey that I have walked through, both at national level and of course supporting countries thereon. So this is really talking about a cup. And in the morning when Partha was introducing, for the ones who are in the course, I was looking at my slides that I did last night, and we look like, did you see my slide when you're sitting here or what happened? But that's good, because then you're really thinking the same things and what exactly happened. So I think the starting point, or where did we start from? And believe me, we didn't do everything as the book. Some things come up, down, maybe the planning, the exploring is coming after the implementation and all that. But the first thing is really to look at, where are we? Where is this country at? Where is this city at? Where is this regional at? Whatever level that you're thinking of implementing, where are we? What is the current status for this country? And looking at many angles from that end. Where exactly do we want to go in the next 5 years, in the next year? Where do we want to be in the next 10 years? So depending on what you're defining and trying to see how you're going to move from there, where do we want to be next month? How are we going to get there? What are some of the potential facilitating and inhibiting factors on the way? So how do we get there from point A? What are some things that we're going to be able to help us get there? And what are some of the things that we're expecting to really make getting there much more difficult? So when you look at assessing the current situation, and some of this wisdom is coming after running through and trying to see for you who are going through, is really, we call it a needs assessment, but at the same time, we're scanning what is happening currently. One of the key things that I saw as I implemented and as I support countries is leadership and governance. And really pinning on it so much is coordination. Coordination at national level, coordination at district level, however your health system is broken down. If you do not assess what type of coordination is there, it's going to be very difficult. Whether you're just starting with one site or you're starting with 10 sites, who are you coordinating with? And in that coordination mechanism, one of the key things, and we did this, like I told you, for the Zambia situation, we did resource mapping way after we had, the vaccination team was running this side, the screening team running that side, the treatment team running that side, and money, one group has so much money, one group is barely making it, one group, say, no, we're okay, we do our own thing, and that should be it. And when we sat down as the prevention, primary, secondary, and the treatment team and did resource mapping, who is doing what at what level? Are they funders? Are they implementers? So you get a lot of people who come in country and they'll say, we want to support your program, your cancer program. And you'll be like, okay. And you'll say, oh, we already have a partner. Maybe you have been asked by government or whatever channel you report to, and you say you have a partner. And maybe other partners will be like, oh, no, they said they already have so many partnerships. But when you come and break down the resources coming out of there, then you know that you need more partners. It could be that they've just, no, we are just coming to train community health workers in cancer screening. So you have to be able to say exactly what they're doing, how long they're going to be with you. Are they there forever? Are they there for a month? And that helps you to plan. And where are they going to be? Are they going to be on a national level everywhere? Are they just interested in a particular area for certain reasons? That helps you to manage your resources much better, so that should another partner come in, you will know that point A is already filled. I want you to go to point B. Okay? partner mapping and resource mapping. Resources, we're talking about how much are you spending. Sometimes you might not get the actual figures, especially from partners, but you should be able to know that they're supporting human resource, they are supporting procurement of equipment, they are supporting you. They are a technical arm that wants to support you in your documentation. They are coming in. This is IAC. We want to come in and help you to assess what it is you're doing, implementing, and that's our role. We're going to set up this program for the next 2 years. We get the results, we give you back, and hopefully you can use those results. That type of clarity is very important. We looked at issues of task shifting, and I'll say a little more once we go to the other end, or task sharing potential. Who's going to do this work? Who's going to be screening? Who's going to be treating? And why are we choosing that cadre of work? Who's going to be doing the social mobilization? How do we move from point A to point B? How is the government currently operating? Is this service already available? It's not available? And if it's not available, which structure are we going to follow? And sometimes you find that government says, hey, we're not yet there where we want to bring this service, but you are coming from an NGO and you say, we can help you until such a time that government can be able to get this service ownership. And government comes in and says, we're going to do A, we're going to do B, and we leave you, and please give us the information that is. And you deal with a lot of cross-cutting issues. We talked about community engagement issues. We talk about leveraging technology on various aspects. How are we going to make this? What parts are in need of technology, and how is it going to move? So I scanned the Zambia National Health Strategic Plan 2006-2011. That was the time that we were starting. And I did this for a reason. Look at the public health priority interventions that government put through in their document in 2006 and 11. I remember this was the time that Zambia had a raging HIV epidemic. Child health and nutrition, integrated reproductive health. Believe me, there was no cervical cancer mentioned there. HIV, STI, blood safety. When you read the whole document, you realize that government was really trying to keep the HIV control because health workers were dying. Normal people were dying in the general population. So the preoccupation of government at this time was to manage HIV. How do we move to the, how do we reduce this high mortality that we're having? And because of that, if you came in and said, oh, I want to bring in cervical cancer screening, they're going to look at you like, how? We have people dying left, right, and center. And this, at the moment, remember, government might say, at the moment, it's not our priority. They are not refusing, but they are looking at what is pertaining in the area and saying, this is not our priority. But that does not mean that it's, oh, they've said it's not our priority, so we're going away. No. So then you have to bargain with government. So how do we move on? Because we were beginning to see that cervical cancer, and the research had been done, that the young women who were coming in, just women who were coming in to access antiretroviral therapy, were coming in, 20% had lesions that were suggestive of cervical cancer. So we were sitting on a time bomb, but it was not being seen in the main sectors or in the main assessments that we're using as a country, because remember, women were dying from TB, from more acute things. Meningitis was taking them. So to be able to see cervical cancer, which would take a bit longer, was not possible. So we had limited, and when we looked at the situation, I was working for an NGO then, and we had done the research. There was limited, and in some instances, no specialized or skilled health workers in the area of cancer. So to say, when you look at oncology itself, of course, we had about 25 gynecologists for the whole nation. We had prevention. There was no one doing prevention. Diagnosis, we only had about 6 pathologists, and services generally. So if you're going to bring in screening, we were using pap smear, and that was being done by the nurses. So that meant that was being done by the doctors. And remember, I've talked about the physician-patient ratio. The doctors were already overwhelmed by the HIV. And they were not everywhere. There were many places, where you find even just finding a trained health worker was difficult in some areas. So innovatively, you look at service delivery, those are some of the things that, and government had competing priorities. There was HIV, there was malaria, there was TB, there was maternal health, and those were very high. But how did we move? So that meant that when we went to setting up, we as an NGO said, okay, can we start small? And this is what we're going to. Government says, yes, start through the government clinics, screening these women based on the data that you've gotten. We have no resources to give cervical cancer. Do you have where you can get resources? And we said, well, we've been targeting women with living with HIV, wrote a proposal for PEPFAR, who later gave in the resources. So from the NGO aspect, 2 clinics opened and in the government facilities. So government tells you you've got the space, you've got everything that goes with that space. You've got you can use the water, the space, everything, the lighting is by government. But we're just not going to dedicate so much money into this pot. But PEPFAR says, we'll give you, because we want to see what exactly is going on. So you look out when you're setting up funding opportunities. So all I'm trying to say is, and this is not a one size fits all. Remember, some of your countries, you go to government and they'll be like, well, we've been waiting for somebody to say something like that. How do you want government to come in? Again, you're going to do your own assessment and try to see, so how do we work with government? Some people will start the NGO route, the way Zambia started. And we targeted women living with HIV, and we had the funding opportunities that came. And political will was high. It grew over time. It didn't start high. And I think you have to work with politicians. You have to work with decision makers, both policy and politics. It's how you present yourself to what is important, why your program that you're bringing is a program that the government needs. And what do you exactly have on the table? And because of the work that started happening, we saw this increased political will. And as things turned out, one point we actually had a gynecologist as a first lady. So that now just took the country to another room. But again, it's using that person that has gone there, knowing the disease, how the disease presents itself, and being able to use that channel to go forward. So if you look, remember, they didn't write anything in 2006. There wasn't even an appearance of the word. But when we went to 2011, 2015, this was what I got from, the next that was written. The government was now committing to, reproductive health programs such as prevention of cancer of the cervix, which have been scaled from one province to all the 9 provinces. The general capacity to carry out cervical cancer screening with visual inspection with acetic acid is being strengthened through human resource trainings and procurement of equipment. Just that sentence means that the government has owned the program. So the program is now moving from you to the government. And it's because of that beginning that you saw, and the government is beginning to see the benefit of what is happening. It also means that you're giving them information and letting them know how the program that you've set up at a small scale is beginning to change. How did we scale up? After we are told, move from 1, we want you to go to 9. And 9 was, the whole country. So ideally in a public health program like cancer screening, we're looking at starting from, and I better know the time. We're looking at starting from the community where it's a population that you want to get to be screened. You're not looking at the ones that are already coming with disease and they're in the clinic. But we started at level 2, of course. One of the reasons was because we realized women who will be going there and have complex cervical lesions will need interventions of the gynecologists because they had been chosen. And before this, we did have a roadmap where we start with government and said, this is how we envision to run this program. So the testing, the treatment, the screening test was agreed upon by government, that we're not going to use pap smear because it was almost impossible in our setting with very poor laboratory infrastructure. Recourse systems we were not going to scale up. So that means we needed to get a test that was scalable, relevant to the context that we were in. And we went to the level 2, that was the provincial or general hospitals, where there was capacity for supervision. We had the gynecologists in those places. We also looked at referral system, because when we had the meeting where everybody was coming in, when we're doing the needs assessment, the gynecologist, I said, you start so many programs at community level and we have no clue. Nobody has taught us. Nobody has even told us what we are doing. And then these women come and they have to be treated. And nobody has trained anyone how to treat them, how to do the lib. So we needed to bring them in. Looking, like I told you, some things were done then. What was the shortfall of this process? What we found is that there is no demand creation at hospital level, because the demand creation is done at provincial level. So you want women to screen at the hospital level and they'll tell you, health promotion, that's a service that's given at the community level. So now, how do you make sure that women hear about this service that you've put starting at the hospital level? In hindsight, we should have looked at having the community having one clinic and the hospital having one clinic, so that demand generation is done. And this is something that, as you are looking at your countries, you can be able to look at to make sure you can start two-sided so that you're getting both sides. And we also looked now at level 2, where now one of the other things we're looking at is sustainability. And part of sustainability in training was really looking at the residence program for the doctors in the obstetrician and gynecologist training, to ensure that they were learning about cervical cancer and its management. And we designed that they spend 1 month in the program. The other part was going out to the nursing community, because we had chosen the nurses that this program was going to be led by nurses as a nurse-led program. So what happens is that then when the nurses are training both pre-service and in-service, they're able to learn about cervical cancer screening. So that means that you are building a cadre. Many years later, when we started with the residency program, rotating 1 month through their 4-year program, it didn't look like it would have benefits. But guess what? When we scaled up, those are the people who are sent to the general hospitals, and they became the focal point, who understood and were able to manage patients. So this is where the program has moved. And believe me, I look at so it started NGO. In about 2015, government said, this can no longer be an NGO, it's on national level, government needs to take over, we need to take this program match. And that means that some of us were absorbed into the government structure now to help shape the national level type of expansion to many. What has happened? Remember I said it started from 2 government clinics, nurse-led, visual inspection with acetic acid. Priority was women living with HIV. And we were using visual inspection with acetic acid, which is now just used for visual assessment for treatment. Ablative and excision treatments provided. The coverage has been from 2, as at, I think this was about May, the country was at 310 centers in 116 districts, 97 district coverage. We had reached 100, but the government added more districts, broke some districts, so yes. And the target for 2021 was to screen 350,000 women. When I was starting the program, when we screened 10,000 women in a year, we actually had the news cover us, and I gave an interview and all that. It was steps. Now there are over 350,000 women targeted to be screened in a year. And screening coverage is at 26%. Treatment rates are at 74%. And there has been wide integration into the HIV and family planning care. What are some of the facilitating factors that I look back at and say, this is what some of the game changers? Ownership by government can never be overemphasized. And looking at the way different governments run, especially when I look at it from my experience at Afro, it means different things to different. Some governments said, start small, and I have some governments that said, look, we got the money and we want to do the whole country. We're starting HPV testing. Just give us a bit of time. That's how we're going to go. Others will say, we'll start phase out. So know your government, know your situation. Okay? Development, implementation, policy on cancer, being present. Is it your strategic plan? Is it your national cancer control plan? Is it just a cervical cancer? A specific cancer that you're looking at, depending on your situation. Some countries will say, we just want to start with one cancer. That's fine. That's your situation. Some countries say we want 3. Some will say we just want to look at cancer holistically. So assess your countries and be able to know what is there. Implementation through government-led structures has helped a lot. That is because then we've had, even when we had at one point one of the big funders pull out, the government was already at the table saying, look, it's no longer health workforce which is, recruited by the NGO, but they said this is going to be part of government work. All the midwives, all the nurses who are doing this work are going to be screening, just the way they give family planning, just the way they give maternal advice, just the way they do antenatal cervical cancer screening should be regarded as such. So which means you take off all the monitoring, all the payments, or they go into the government bill, because those are nurses who are employed by government to do reproductive health services. And engaging of existing public sector health workforce, like I have said, and also having establishment at national level that are coordinating cancer. There has to be your technical working group, your committee on cancer, whatever you're calling it, there has to be somewhere where coordination, and we see, even from the African perspective, is most countries lacking this coordination. So you'll find Organization A is moving to X, Organization B is heading to Z, and countries are pulling, no, we are the ones in this province. Instead of sitting down and say, okay, you'll be in this province, we'll be in this province, we'll be in this district, and everybody accountable to the government. Financial inclusion is what we saw. Cervical cancer screening is part of the National Health Insurance Scheme. So when you're sitting at the table, it's easier to advocate and push as a group for things that will want to happen for that particular disease. Consistent collaboration with local and international partnerships has been there, and having a scalable screening method. Of course, we come in with transition to HPV. Because you've built a foundation, it's much easier to move to the next stage. And leveraging existing, we had the World Bank giving maternal child health resources. And I went and I said, but why are you not including cervical cancer? He says, okay, can you put up a proposal? And we did put up a proposal, and we did get a substantial funding and they said, go where there's list services and we want to support those areas to be supported. So you have to look beyond the same areas where you're getting resources all the time. Strong community engagement, high political will. And we've got the challenges there. I want to leave enough time for questions and answers, and how you answer. There are social cultural issues that are coming in, and ensuring you have strong community engagement. If you're dealing with HIV, bringing your community advisory groups to help you, community-based volunteers as well. And in Kenya, they moved from HPV testing, where they're using the community health workers to take the kit, get the specimen, get it tested, come back with the results, and those who need to go back for further assessment are then going back. So the woman is in the community, and the community-based health workers who are on the government payroll, they have added cervical cancer screening. So they've been taught on how to instruct women to take a specimen. That also frees the nurses from seeing everyone, but seeing the ones that have got disease. So these are different models that have happened in different groups. We had very low treatment rates. It's all about mentorship all the time. Some of your of the countries be like, we train, tomorrow they've moved them to another program. We train, and we said for every new center we open, 3 people are trained. And hopefully, please avoid training people who are in administrative roles. And finally, sustainability is difficult if there's overly overdependence on the donors. Everything, the donor does it. And the moment the donor changes, moves around a few keys, then the program is shaking. Ensure the whole continuum of care is advocated for. Ensure that you're moving together. If you have primary prevention, secondary, and treatment, of course, different partners have got different interests, but you have to come as a front, because you are talking about one disease. Ensure robust monitoring and evaluation within the government structures. That's what Andrew was talking about. You bring very complicated systems. And for a long time, we collected data as the NGOs which were gathering, and then government would be like, is this data in our system? I said, no, we'll share with you. Said, no, you don't come. It's our data. It's our population, our people. You don't come and say, we will share with you. We use our system. You can collect extra data that you might be needed by the NGO, but the basic data, set up indicators, and you have, regional frameworks that have been set up, on the acceleration, the strategy for the acceleration of elimination of cervical cancer. Strengthen and link to cancer registries. Cancer registries are not invited to the table. They're just collecting data in hospitals. They are not in the technical working group where people are making decisions. And then you come back and say, but we don't even know if we are improving, if less women are dying or more women, or what stage we're finding. That's why you have those registries. Start linking up data and making sure we're working as teams. Community engagement in dealing not only with social cultural issues, many issues that will come to your program. And it is important to align to the various global and regional standards that are there that we must do. That must be my last slide. And I hope I have gotten what Andre had brought out and broken it down to what happened, what went well, and what still can be improved. Thank you so much.
Thank you, Sharon, for this fascinating talk. We have more than 50 participants who have joined online. So let's start with the questions and answers round. So we'll first take the questions from the floor here. So please use the microphone.
Thanks, Sharon, for a wonderful talk and presentation. Just wondering about the patient navigation part, how to facilitate. I'm from India, where 80% of the population are farmers. The agricultural is the main occupation, and a lot of difficulty in terms of topography and geography to come or reach to the resources.
And thank you so much for that question. Patient navigation is one of the key issues that we grappled with. And that shows even in the treatment coverage that countries will present, part of it is really the drop from point A to point B. Technology was one of the things that we leveraged, combining with the WHO. We used the mHealth technology to begin with, where we looked at raising awareness and people could get messages on the phone. The next stage was really looking at how we can set up appointments, so that it's not only the patient not going, it's the patient going and finding that the doctor is in theater doing something else and they're told, come another time. So to be, even for treatment, it's the same. We have made sure the screening nurses in Zambia are also connected to the registry at the cancer treatment center, because women would come all the way only to be lodging for 2 weeks because the appointment can only be available that time. It's better, I'm told, come in 2 weeks than me starting off and being told go back and come back in 2 weeks. It's money, it's time. Using the community health workers that are there as part of the navigation between the screening center and between the screening center and the community is very important. It's also ensuring that actual raising of awareness, whether it's at the community level, are you using the various forms of religious and traditional platforms where women come together? So we found that using the women groups that I have in churches for us and raising awareness and letting them know the stages and what happens was one of the increase of people knowing that this woman needed to have this type of treatment and where to go. But technology helped a lot in setting up the appointment. And then the other thing that happened is that a policy was done by government that any woman who had suspected cervical cancer, and especially if they had a result already, we skipped the other normal referral gates that we have. You have gatekeeping, and then when the woman goes without going through the district or the regional office, they get a fine. Okay, so that was removed for cancer. That was a policy that government made to enhance that navigation, because there was nothing more a woman will get from there, since treatment was only at the capital. So what happened is, if a woman has a diagnosis of cancer, let her start off from there and just go straight into the cancer treatment center. So that meandering of going to see Dr. A, Dr. B, who will merely write go to Dr. B, and Dr. B writes go to Dr. C, let her move from A to Dr. C and skip all the others in between. Helps. So there's technology which helps. There's also looking at the policy and trying to see, are there any ways we can be able to navigate and remove some obstacles for the patients that are going in. And when they're going through the treatment, you can also have another technology about treatment. Where are they coming? The most difficult aspect, which I see most countries still grapple with, is the communication from the treatment center to where the woman got screened. Okay? So because where the woman got screened is most likely where she stays, and those people must be informed of what has happened to this patient. In the same way, when the patient goes back to the community and you can't trace them, it would be much easier to call the health worker there and say, look, Mrs. X has not come back for a follow-up treatment or review. What has happened? They will use their channels at community level to go and find out where this woman is. But what happens is that when we screen in the screening program, and part of it is diagnosis, we do their diagnosis as well, and we tell this woman she needs to go for treatment. That's it between me and that woman. Once the diagnosis is done, it shouldn't be that way. And then now, from the diagnosis, the woman will move, she gets treated. I don't know what happened to her. So having systems, even the way we are setting up our databases, should be able to do that. So use of community, available community, and we have a navigation desk, which is set up by a cancer support network in Zambia. Zambia Cancer Society and two sisters who've got, they're kind of getting a container, but the Zambian Cancer Society has a desk. So what happens is that any woman who comes in and they have cancer, they want any patient for that matter They help to navigate where you're going to get treated, where you're going to get your tests done, and how you move, so they run you through the whole journey of treatment. But that only happens, you can try as much as possible, but the patients are also many, to have 3 or 4 cancer navigators. Once they are with this patient, the other ones are ending up waiting. I think it's important to use existing social cultural channels already there, together with what you have created for sustainability.
Yes, Bishop, please.
Thank you very much, Sharon and Andre, for the excellent presentation. My question comes from the practical experience in Nigeria where a pilot HPV testing was done. And before we started the program, I approached the first lady of one of the states and I looked at the cost implication and she was like, no, HPV is gold standard. So we are rich and we should not say we are poor. So we should try to do that. But after the pilot program, I now meet her that, look, can we scale up? And then when we calculated the cost of procurement of the HPV test kits, it's more than the health budget for the state. Practically, the pilot project is off. And just to ensure sustainability, just to ensure that something is done, we began to now revert back to VIA, just to ensure something is, because I am now asking this question in view of your statement where you mentioned categorically that VIA is only now for triaging. But for low resource settings, can we also start looking at American Cancer Society, American Society for Clinical Oncology resource stratified framework where HPV and VIA is used as a foundation and HPV can be built upon that when resources come. And when there's no resources, you go back to a VIA just to ensure that something is done for the people. So, and to Andre, regarding implementation, what structure can we use to probably be talking about cost effectiveness? Because for me, based on local experience, HPV is effective, is efficient, efficacy has been proven, but I'm not aware of a non-research, coordinated environment where HPV has been shown to be effective in low resource settings. And I think one of the biggest challenge is budgeting. So I was looking at, is there a research implementation research framework that focuses on budget as part of implementation for sustainability? Thank you.
Okay, and I will let Patha come in on the question about, so we have the WHO Global Strategy for Accelerating Elimination of Cervical Cancer as a public health program. And after a lot of research, after a lot of modeling, that has gone into it. It has been found that if we're talking about this acceleration, thinking of even elimination in this century, we have to move to a molecular test like HPV test, okay? What hasn't been said is that, so if while you are scaling up, nobody says you should stop what you're doing. No, that has not been the instruction, that stop until you have enough money. No, but countries have to be aware that you're using VIA. It means that for you to reach that elimination, it's not going to be possible even in the next. So hence, from the science perspective, from the cost perspective at the end of the day, when you look at the lives that will be saved and the amount of money that you save, and the high negative predictive value that we have, that is why HPV testing has been chosen. So what has happened is countries, there are many modalities which are beginning to come up, and most of them will be coming up. We have CHI, UNITAID that are trying to look at the market shaping and trying to help countries in how we lower. We see that PAHO has used the Cancer Fund and the pooling together of countries buying together. The issue is if you're doing a pilot in a province and you scale up within that province to a few facilities, it's going to be very expensive. But if Nigeria plans and says we're having even 2 states or 3 states buying together, you're going to get at a much cheaper cost. I think the challenge for for the Africa region is really about how we're going to pool together to get high volume. That is what has happened to until prices will start going down, but we need to find innovative ways. But you also find that some other partners, you have Chai, and you need to go to Chai, to United, and see how they can help you to get where the resources, the sources are much cheaper and affordable to you. But if you sat together in a MOCO, we sat as coordinated as countries and come as a front like PAHO, then we'll be able to buy, and we don't buy for one province, but we're buying for a region. That's why I'm telling you, at the end of the day, you still come back to political will coming into play, because the people who eventually sign off that check has to be from a political will. If Gambia says, look, Gambia is only going to buy 20,000, okay, and Nigeria said we'll get 2 million. Zambia says we're going to get 5, and everybody puts their bid, and we have much more tests. It means the cost, because of the volumes, will be much cheaper. But if I go just for my setting, it will be much, much higher. And until those volumes are reached, like we have learned from the HIV program, people will be finding that it's very expensive to do it on your own. So we need to put our heads together, and perhaps that's where all the regional bodies coming in, ensuring that we help countries come to these market shaping agreements, which will be much better. Martha,
yes, you responded to the question very well. Cost effectiveness is something very specific to the country perspective, because the level at which an intervention is found to be cost effective varies. Say, for example, UK may decide any intervention that costs $20,000 per life saved is cost effective. Nigeria may decide, no, for us, the cutoff is 10,000. So that's very country specific. Second thing is, at what rate you are getting the test, from the companies. And there, as Sharon mentioned, we need to be creative in the form of having the combined purchasing power, and then bringing multiple companies to the table, and then negotiating with them. So all those things have to happen parallelly, as you don't stop the VIA-based program, you keep the VIA-based program, because we have to keep in mind, the screening test is part of the jigsaw puzzle. But in the screening jigsaw puzzle, there are many, many other things. We have to think about the management of the skin positives, treatment, the advocacy, then quality, all those things. So all those things need to be there. And then as we are prepared, we can replace VIA with HPV testing. So it's an informed decision, but then it requires time. And then also we have to see how the cost comes down. Andre, would like to respond to the question?
Just add one more thing on this, right? As Partha said, Sharon said, cost is specific. We need to cut down the cost, right? There is many ways to move forward on that and go as a group, as a nation, as a group of countries. But also we need to think that, when you think about the elimination, we're talking about target 70% of the population that's eligible getting screened. And you're correct, it's too expensive now because you do that calculation, but you're probably below 30% coverage with the VIA, right? And if you go in that direction, how long is it going to take for you with the VIA to get to 70%? How many people are going to need to train? The investment you have. So that also, has a huge cost, right? About lives that you're not doing diagnosis of pre-malignant lesions that you are not treating. So that's the reason WHO is saying that the only way to eliminate, or the faster way to eliminate, right, to get to 70% is by the molecular test. Because we see more and more the possibility of the cancer screening programs to do the jumps other than implementing some new technology like a test, you're going to increase maybe 3-4% a year. So we are talking, if you're below 30, it might take you 15 years to get to 70%, and not the people that you need to train in between. So that also need somehow go in your equation. Right now, the equation that's how much cost, that's going to take all the funding of my state, makes not viable at all. But I guess we need to find ways to make it feasible. And
Thank you, Andre.
Thank you.
Yes, please. Go ahead.
Thank you, Sharon, for the good presentation. My question is, I've seen the great work that you have done in Zambia, and right now you are the cervical implementation lead in Africa. Have you tried what you've done in Zambia in any other African countries, and what are the challenges or way forward have you seen? Thank you.
I think so. With other African countries and where we have started with, we have a colleague of mine who was working on the West African side, and I was working on the East and Southern African side. Is really, we have moved a lot of countries to having policy to begin with. So what we found is that most countries, there were some countries that have never even written something to say this is where we want to go, put it down, and we move that way. And to help in coordination, on the West African side, especially Francophone side, you see that they actually on a monthly basis, we have it on the East and Southern Africa ECHO, but they have ECHO for cervical cancer particularly every month. And they're discussing country by country and challenges and exchanging ideas, which is excellent. And you find that as we have looked, for example, supporting Kenya, supporting Rwanda, they have different programs that you see that are actually, for example, I told you about the Kenya program where they're actually using community health workers, yet to be scaled, but they've started using community health workers to collect, to go with the kids at community level, give. And that's also what Andre is speaking to. It's a very faster way of scaling, because these are going, and one community health worker can probably move into 20 homes. That means 20 women have been seen in a day and will come back with results, and the ones that need, because they know them on a personal level as well, can go back into the community. Also helps to improve retention and losing, loss to follow-up. So that's a good model that we're looking at, and we're interested in seeing how it's going to scale up. And you see Rwanda, that's want to go almost to the national level of scaling up HPV testing and planning towards that every facility should have HPV testing, because they see the value and they want to move that way. They already have an excellent vaccination program. They've got treatment, but their vaccination, and now they want to put that into treatment. So those are the countries that you work with, you're trying to help with. I've been to Uganda and I was with Fiona. I went to Uganda, I was in Fiona. We're really looking about data as well, and how we could support data to make sure that it's informing decisions as well. How do we support cancer registries? Some of the work that Fiona that is doing in Uganda is tremendous. So Zimbabwe, it was also towards cancer registry as well. Zimbabwe has got one of the best cancer registries in the country, but we're trying to see how do we get the screening data in a much more organized way to be able to inform decisions. So Zambia now is how do they transition and become sustainable as they transition. One thing with the Zambian program is now we must be looking at the impact. How are they? We've done some of the downstaging, which we see is improving. Most of the people who are coming in with advanced disease, with the awareness, you're beginning to see more of early disease. It's a good sign. But now we also need to know that we're actually beginning to tilt the disease. You've scaled up. I think what needs to be enhanced, and Parther and team as IAC has been doing that, is how do we improve the quality? How do we make sure that we're getting people treated and treated the right way? So these are some of the sharings that have been going on. And we are hoping that in the next phase, we're going to bring more and more countries engaged. But I think we've been engaging with some of the Ministry of Health people at regional level on really a much more detailed way, but much more needs to be done.
Thank you. Thank you so much. I think we'll have to wrap up this session. Thank you, Andre. Thank you, Sharon, for this excellent session. So, and then those who are joining online, thank you for joining. Thank you.